Okay, good evening. Yeah, we'll be back from Easter holidays. I think you enjoyed everything, and now you have to be back. Yeah. Yes, I kept quiet for like 3 days from Saturday. I'm not doing any class because I let you enjoy. But now Easter is done. We have to continue from where we stopped. We stopped at atrial fibrillation, and we had done ECGs, some examples like 2 of them, showing how to interpret ECG generally, but capturing atrial fibrillation. At least one ECG we saw. Now today we are proceeding to another type of a tachycardia that we can see on the ECG, and that is a wide complex tachycardia. The first one was the narrow complex, and we saw all the differentials of narrow complex tachycardia, including atrial fibrillation, atrial flutter, sinus tachycardia, supraventricular tachycardia, that is paroxysmal. So all those ones we saw. Atrial tachycardia we saw, but we said the most important, sinus tachycardia, very common. Atrial fibrillation, because of its risk of clotting, forming blood clots, and then atrial flutter, because it can easily convert to atrial fibrillation. Now today we are going to see more, or another type of tachycardia that we saw in the ECG, that is the wide complex tachycardia. Before, just as a recap, we said what is a wide complex and what is a narrow complex. We said the QRS duration on the ECG of more than 110 milliseconds, of more than 120 milliseconds on the ECG, that is a wide complex. And then a QRS of less than 110, of less than 110 milliseconds, that is a narrow complex. We reminded ourselves, how do you calculate the QRS? We saw the calibration, ECG calibration, that one very small box is equal to 40 milliseconds, and then one big box equal to 200 milliseconds. That was the calibration. So basing on that, we are going to see what a wide complex mean, and the narrow complex finished already. So wide complex tachycardia, we said 2 origins are there, either supraventricular or ventricular. In narrow complex tachycardia, we said the impulse originates from the atria or AV node. From atria or AV node for AV node dependent tachycardia, but not necessarily originating from AV node, but it is dependent because it forms a circuit, a re-entry circuit there around AV node. So that one was narrow complex tachycardia, always from up. For wide complex tachycardia, the impulse origin can be both supraventricular and ventricular. That is a big point to note, that in wide complex tachycardia, the impulses can originate from anywhere, whether atria, or ventricles. Doesn't matter. That's one big difference. But that supraventricular, we said always up, but ventricular origin, like wide complex, it can be up or down. So we are going to see when they are from up, like supraventricular. So when do impulse originate from supraventricular chambers, that is atria, to form wide complexes. So how do impulses from supraventricular origin or with a supraventricular origin form wide complexes? How do we form wide complexes when the impulses are from supraventricular origin? One is going to be if there is a bundle branch blocks. When we have bundle branch blocks, like right bundle branch block or left bundle branch block. So in case of this one, it comes as a tachycardia, and then there is RBB or LBB. Then we are going to form a tachycardia with wide complex. 2, if there is an accessory pathway. If there is an accessory pathway, right? What is an accessory pathway? An accessory pathway is the one that, in addition to the normal conduction system, it is also existent, right? A band of myocardial cells that cross, persist and then cross the what? The AV ring, then to enter the ventricles. This is what we said initially that is supposed to be. For more, I'm doing lectures on physiology and anatomy. So these things I'm explaining them from there. So these ones you can find them on YouTube or other videos. So they are there, well explained. Accessory pathway. So this is what we have initially or normally. We have which node is this? SA node. Which node is this? Very small. AV node. Then what is this? Bundle of His. Then what is this? Right bundle branch. What is this? Left bundle branch. Of course, 2 divisions are there. Anterior division, posterior division, and then of course the septal branch is there. So we have internodal fibers. This is normal. That the impulses move from SA node through the internodal fibers to AV node, bundle of His, right and left bundle branches at the same time. But in some circumstances, some abnormalities are there, they arise, and then you find that another pathway is there. Here we have, see, I'm drawing I'm drawing a right atrium here. This is the right atrium, and then here we are forming, these are the ventricles, and this is the left atrium. These are the tricuspid valve, and then this one is, it is very rough, but leave it. This is a septum. Very rough. Septum, the blue line is septum. This is LV, and then RV. This one, the left bundle depolarizes the left ventricular side, right bundle depolarizes the right ventricular side. So we have these two valves here. There is a line dividing the atria, separating the atria from the ventricles, and this line is fibrous. It is a fibrous tissue. It doesn't allow conduction. It does not allow passage of impulses from the atria to ventricles directly. We don't want that. You don't want impulses to pass from the atria to the ventricles directly. No, they have to pass through this gate of AV node. This is a gate. The AV node is a gate. It must pass through the gate. Now, under some abnormal circumstances, something remains. Something will remain. This is the myocardium. But instead of impulses passing here, there can be a pathway, maybe a bundle of myocardium that bypasses this line, and it can just come like that, just insert somewhere here. It remains, it bypasses, and it carries the impulses from the atria directly to the ventricles without passing the AV node. And this, if it happens like that, if it happens, then it will be called an accessory pathway. It will be called an accessory pathway. In simple terms, it appears like that. Just a band of myocardial fibers that conduct impulses from the atria to ventricles directly without passing through the AV node. So if such happens, then it will produce a wide complex tachycardia. We shall see how, but it will produce, probably in our lectures on arrhythmias, in physiology, cardiovascular physiology, we shall see it, how it exactly produces, or in advanced ECGs. This is basic. We shall see how it produces a wide complex. But for now, it is like that. So, impulses from supraventricular side, that is the atrias, can produce wide complexes if there is RBB or LBB, or if there is an accessory pathway. That one, those two, are enough for now. So next, impulses from ventricles. That is when, because from ventricles, if we have the impulse source or site is ventricular site, that is already against the normal conduction system. We said the only way we can reproduce a narrow complex is when impulses move from SA node, internodal fibers, to AV node, and from AV node, bundle of His, from bundle of His so this direction SA, AV, bundle of His, right bundle, branch, and then left bundle, branch. This direction will produce narrow complex. If the impulses, for example, they originate below this line, then it will produce wide complex. If it is here, it may appear to be a narrow complex because it is within the conduction system. If the impulses are from the bundle of His, it is within the normal conduction system, so it can go and produce a narrow complex and normal one. If the impulse is from the AV node and it goes down, it can produce a narrow complex, or it produces a narrow complex and of normal morphology. And now if we have this direction of impulse generation, if for example is from here, this is the source. This is a ventricular myocardium, so we have the source of impulse, that one in green. These impulses will move from this side to this side going upwards. So that one, it will be against the normal conduction path. So whenever impulses move against the normal conduction path, they will produce, first they will move slowly to, they will produce a wide complex because they are moving slowly. So impulses from ventricular sites produce wide complexes because they move because they move against the normal conduction path. This is not the normal, so in opposite. So what is the effect of moving against the normal conduction path? That is propagation with the slow velocities. This on the ECG is reflected by wide complexes. So in ECG we see this one as wide complexes. Yes, yeah, that is opposite direction. That is how it is produced. If not, then we are going to see others. Otherwise, for impulses from ventricles, that is why they are producing wide complexes. Now, other things, we can say differentials. Wide complex tachycardia, differentials. What are the differentials? When you see wide complex tachycardia, what do you think? What are the possibilities that this one is there or not? Or what are the possible diagnoses with the wide complex tachycardias on the ECG? One, it is ventricular tachycardia. Ventricular tachycardia, that is VT. 2, ventricular fibrillation, this one is VF. 3, based on what we have said, SVT with the aberrancy, that is SVT with aberrancy. What is aberrancy? Aberrancy is anything, or is when the impulses pass through the normal conduction system but with delay. 1, when there is right bundle branch block or left bundle branch block, impulses pass through the normal conduction system, but because of slow conduction here, because the branches are blocked, the way is blocked, they will delay. So 2, yeah, 4, SVT with the, that is WP, leave that one there for now, nothing much to add. 5, you can have AF with the WPW or bundle branch blocks. 6, it can produce paced rhythms. When the patient is having a pacemaker, there will be wide complex because the impulse origin is from ventricle. Pacemakers, the pacemaker lead is put in the ventricles, so that is already wide complex. Now if it becomes a tachycardia, then it will be wide complex tachycardia. We leave it there, nothing much, like pacemaker mediated tachycardia. 7, hyperkalemia, but this one mostly bradycardia will be there, not tachycardia. So these are possible diagnoses if there is wide complex tachycardia. These ones are possible. So what is important, most important, is this and this. Why? They are hemodynamically unstable. This one will be most in bradycardia, so nothing much. If we've already seen, with WPW we are not going to see now. It's a bit complex, more advanced. SVT we've already seen. Bundle branch block we shall see. They are basic things. We shall see them. Paced rhythms, very advanced, we are not going to see. Hyperkalemia, that one I will handle the other side of physiology. And ECG, normal ECG in hyperkalemia. So these are the differentials. So my focus is going to be these two: ventricular tachycardia and the ventricular fibrillation. Ventricular fibrillation, nothing much to do, but ventricular tachycardia is the most common. Yes. So I'm starting with number 1. Number 1, that is ventricular tachycardia. What's the ventricular tachycardia? We have already said the impulses are from the ventricles. That is one thing. It is a wide complex tachycardia. 2. Now, what is the heart rate? We know above 100, that is a tachycardia. So wide complex heart rate above 100, possible thing can be a VT. Why VT is important? Why? Why need to know VT? Because 1, it may be hemodynamically unstable. Hemodynamically unstable, what do I mean? Yes, hemodynamically unstable. It is, can appear with hypotension, hypotension can be there. Patient will be complaining of palpitation. It's very disturbing, but most of the time, most important thing is hypotension, hemodynamics. So patient with palpitations, syncope, dizziness, all the things the patient will come with them. So these are signs of hemodynamic instability. So if it comes like this, and 12 lead ECG has to be done. So a patient coming with these ones, resting 12 lead ECG to be done, or must be done. And then rhythm analyzed, where patient may come in, the most important thing in cardiac arrest. Patient can come or can be in cardiac arrest, only to see, and the cause can be a VT if the rates are very high, like 200 plus. This one can cause cardiac arrest. So 12 lead ECG resting if the patient is stable, and analyze. Patient in cardiac arrest, you have to attach the monitor first, start CPR, as you attach the monitor and make the defibrillator ready. It has because it may be a shockable rhythm or an unshockable rhythm. So if the patient is in cardiac arrest, CPR and then as you attach the monitor, at the same time the defibrillator should be made ready, because it can be a shockable rhythm or an unshockable rhythm. We shall see that one if that time comes, what a shockable rhythm is and a non-shockable rhythm. But this VT is a shockable rhythm. So you have to attach the monitor, analyze the ECG, and then decide on what to do. If you confirm it's a VT, hemodynamically stable, you can use cardiovert with the medicine or medical cardioversion like amiodarone you give. If hemodynamically unstable, then DC shock has to be given. Here, causes of VT, there are many causes. We are not going to go through that. We shall see in the other lectures. So how to say VT? How to diagnose VT on ECG. This is the main thing. How to see VT on the ECG. First, we have already mentioned some of the things. You need a tachycardia. Second, wide complex. Tachycardia, wide complex. Another one, you need rhythm analysis. Another one, you need to check for AV association. I'm going to explain this one because it's very important. It will be applicable in other abnormalities or dissociation. And then others, they are advanced. So these ones, we are checking this one first. First, we need a tachycardia, and then we need to confirm that this is wide complex. We have to check the rhythm. Is this regular rhythm or irregular rhythm? And then, second, we need to check for AV association or dissociation. Is there AV association? What is AV association? Atrioventricular association. Is it true that each P wave is followed by QRS complex? Is it true or not? So if we see that they are not associated, there is no association, then we confirm that one will be AV dissociation. If it is true, each P wave is followed by QRS complex, or there is a relationship between P wave and the QRS complex, either before or QRS complex after P wave, or P wave after QRS complex, we say there is AV association. So that one discredit a VT. So if there is AV dissociation, this one will favor VT. AV dissociation shows a VT. AV association, no VT. So I'm showing now how will it appear on the ECG. For example, we have this ECG. This is P wave. This is a normal one. That is the normal one. Now, for VT, to lose most of the things, to be like, maybe P waves are there and to be like so I'm naming these ones. So if you compare these two, they may look different. One, direction of T wave. Another point I've added, discordance between T wave and the QRS. In the normal ECG, if majority of the QRS complex is positive, here the majority is positive, almost two big boxes, less than one big box, or one line. So majority of this one is positive. Then T wave should be positive also. Again, if QRS, the majority of QRS is positive, T wave should be positive. But also we said that the normal T wave is positive. Don't forget that. We said the normal T wave should be positive. It shouldn't be negative or inverted. If I say inverted and negative, they are the same. A normal T wave should never be inverted, only in AVR and sometimes in lead V1, not 1, lead V1. But anywhere you see a wide complex, duration from here to here, that is around, maybe around 140 milliseconds. Positive, this is a positive wide complex, and the negative, this is T wave, this is R wave, this is T wave. T wave. Inverted T wave, this one shows the complex is from an abnormal site and it's wide because the impulses moved in a wrong direction. And even the depolarization or repolarization, we said R wave, T wave is represent ventricular repolarization. It was also happening in a wrong direction. So everything is wrong. The complex is wide, positive, repolarization is wrong, it is negative. You should confirm this, that T waves, they are inverted or they are in opposite direction to that of QRS complex. If it appears that it is wide and T wave is positive, maybe it is tending to become a segment elevation, MI. But in most cases it will be inverted. So T waves are inverted in wide complex tachycardia, like in bundle branch blocks. T waves are inverted. Paste beats, T waves may appear inverted. Everything. So after confirming this, like T waves are inverted, like in opposite direction that of the complex. If the complex is negative, T wave will be positive. Always negative complex, T wave positive, like this. This is the RQS complex and this is T. So it will appear like this always if the rhythm is from the ventricles. So after confirming this discordancy, this is what I mean, they are in opposite direction. Discordancy mean they are in opposite direction. Then you check the rhythm. If the rhythm is regular, most of the VTs, again, most of the VTs will have regular rhythms. Most. So what is the remaining? Unless they are polymorphic. We shall see what is polymorphic. Like VF. BVF is a polymorphic VT. So it will have irregular rhythm. So irregular rhythm, it is a feature of a VT. Now the next is to check for P wave. This is P wave. It is there, no? Also here it is there, but here no, and here they appear to be 2. Here they appear to be 2. And this one is just so here. This one is also P. You have to check for association between P and the QRS. P and QRS. Here it is there. You have to check how long is PRI interval. Maybe here the PRI interval is here the PRI interval can be around 120, and here it is around 80. Here it is around 130. This one is 40. This is PRI interval. So PRI interval changing. That's how you track the AV association. After identifying P waves, that P waves are there, check for association. How? By checking the PRI interval. If it's the same, it should be the same. If it's not the same, then we can have 1 AV blocks. 2, it is true that it is same, PRI is same, but the time at which the complex come is different. It comes earlier sometimes the other time it comes late. So if they are not equal, that one shows unequal PRI intervals confirm AV dissociation, and that's a VT. If it is a wide complex tachycardia with AV dissociation, confirms a VT.